I'll be speaking a little bit about the program that we've implemented at Save the Children in partnership with World Vision in Niger, and demonstrating how an integrated approach to address livelihoods, agriculture, and health, especially focusing on household decision-making, can have really positive outcomes across different areas. I'll give you just a little bit of context on the area that we work in. Niger ranks number 2 from the bottom on the UN Human Development Index and near the bottom on the Gender Inequality Index. It has the highest fertility rate in the world, with women of reproductive age having about 7 children each expected to have. Poverty, inadequate birth spacing, malnutrition, food insecurity, and harmful practices like child marriage also play a really strong role in high rates of maternal and child mortality. In this area where we worked in Maradi, we've seen that it's the highest has the highest regional prevalence of poverty of 67%. Third of the population is at risk of food security, and 16% is actually food insecure. These contextual factors, compounded with some of the gender norms about the roles of men and women, translate in chronic food and nutrition gaps, inability to make resilience-enhancing, nutrition-sensitive investments. We also see that socioeconomic constraints that are faced by women in this context limit their access to skills, opportunities, and information, in which limits their ability to anticipate, respond, and adapt to interrelated shocks and stresses. According to the research that we conducted, beliefs in social norms or family members' income make it really challenging for members of the household to make decisions around nutritious food for children. So, in another statistics around child marriage, which is prevalent in this particular area where we work, adolescent girls are more likely to be married and mothers by the age of 18 than to have finished primary school and know how to read, contributing to the lowest women's literacy rate in the country. So that's kind of the context against which we are working here. LAHIA is a program that is focusing on 4 different areas of improved nutritional status of children under 5 and pregnant lactating women, increased access to food, reduced vulnerability to food security shocks, and also looking at improved participation by women. It's really anchored in understanding of investing in women's empowerment and bringing men into the dialogue as accelerators of outcomes across all of these areas of focus. In terms of our approach, there are 3 areas that we're focusing on. So we have a triad of health volunteers. We really stress the integrated approach because rural life and family life is not unidimensional, and inadequate consumption of nutrition foods undermined by cultural norms about health and nutrition, and then compounded by rigid gender norms about the roles of men and women, are really can have devastating consequences. And so addressing household decision-making, improving household-level communication, and addressing the inequitable status of women have been at the heart of this program. So the 3 areas that you see here are the triad of health and nutrition volunteers. These are 3 groups that it goes beyond measuring messaging or delivering messages and investing in, but also we're helping communities and new mothers around a common goal of healthy child growth. So we have peer educators following women from pregnancy to their child's 2nd birthday to ensure access to health centers, health workers, and oversee ensure that children grow until they're 2 years of age. They grow. They waited for underweight, screened for acute malnutrition, and receive appropriate services. We also have the Women's Savings and Loans Group, which is Mata Masudubara, or Women on the Move. And this is a registered women's savings group and loan group that is recognized by the government. And we've been able to train some village agents and facilitators who are responsible for routine monitoring and providing financial management. And through these groups, excuse me, through these groups, it's been possible for women to make, thank you so much, to make women from the poorest households to make decisions about where to invest the money. And some of them went into short-term loans and that are adapted into individual needs, and to meet food, nutrition, social needs of the households, and also purchase agricultural inputs. And thirdly is the husband schools, which is comprised by men with the goal of promoting the adoption of range of positive behaviors among fathers. Our approach relies on building a cadre of men that model best practices, advocate for maternal and child health care. Those schools are there to amplify the work of the triads and women's groups by addressing some of the underlying cultural and gender norms related to household decision-making, health seeking, and nutrition. We've chosen these men based on their good standing in the community. It's kind of a prestige to be chosen to be part of these groups, their work ethic, and their leadership ability. Given some of the cultural and religious misgivings about household decision-making, we also include religious leaders in these groups. That's been really important. So the groups of men who then become facilitators and advocates for, sort of has amplified within their communities to become advocates for this across communities. Improving community health and nutrition by improving women's and men's awareness of issues affecting reproductive health and family planning has been one of the key pieces of the husband schools. We've worked on improving men's knowledge, so it's not just it goes from both knowledge and understanding of the issues, but also changing norms around men's more equitable participation in the household. And then gradually at the end, we have seen that many men have become those agents of change within their communities. Some of the impact that we've seen, really been very positive. We've in addition to some very positive health outcomes, we've seen increase in attendance of antenatal and postnatal consultation, assisted deliveries, adequate birth spacing, improved infant and young children practices, but also some of the qualitative research that we've done has seen consistent improvement in communication and joint decision-making in the household level related to agricultural production, household consumption and nutrition, children's education, especially with investment of girls' education, and also delay of child marriage. In terms of sort of lessons learned from this, and I have 1 minute left, we're part of the Sahel Resilience Learning Project that has been working with Save the Children and other partners since 2014, and we'll be focusing on sort of 3 areas of research in the next few years, looking at individual internal capacities, so human capital, agency, literacy, education, self-confidence, at external opportunities and resources. So what are some of the barriers to financial resources, services, access to markets, livelihoods options, community participation and leadership, and lastly, some of the external constraints or barriers, such as formal and informal structures, sociocultural and religious norms, etc. And as I said, this has been strong learning for us around how do we integrate approaches around household decision-making, how we start from family, start working with men to mitigate some of the impacts of women's empowerment and bring them into the space of household decision-making together. So thank you.